Welcome to the Society of Critical Care Medicine's Sepsis Redefined webcast. My name is Craig Coopersmith, and I am the immediate past president of the Society of Critical Care Medicine. It is now my pleasure to introduce our presenters today. Both of our presenters are both past presidents of the Society of Critical Care Medicine. Our first presenter, Cliff Deutschman, MS, MD, FCCM, Vice Chair of Research, Department of Pediatrics at the Stephen and Alexandra Cohen Children's Medical Center in New Hyde Park, New York. Dr. Deutschman also serves as Professor of Pediatrics and Molecular Medicine at Hofstra Northwell School of Medicine in Hempstead, New York. Dr. Deutschman was the co-chair of the Sepsis 3 task force. Our second presenter is Mitchell M. Levy, MD, MCCM, FCCP, Chief of the Division of Critical Care, Pulmonary and Sleep Medicine, and Professor of Medicine at Warren Alpert Medical Director at Brown University. Dr. Levy also serves as Medical Director of the Medical Intensive Care Unit at Rhode Island Hospital in Providence, Rhode Island. Dr. Levy has been a long-standing leader in the Surviving Sepsis Campaign since its initiation. The webcast will include approximately 15 minutes of content, followed by a question and answer session. At the end of today's webcast, attendees will be able to understand Sepsis 3 and related clinical assessment tools, recognize the rationale behind the new definitions for sepsis and septic shock, and understand the relationship of the new sepsis definitions to bedside screening and treatment for sepsis patients. CE/CME credits are not available for today's webcast, and importantly, the webcast is supported by the Gordon and Betty Moore Foundation. You are invited to ask questions for our presenters throughout the webcast. You may do so by typing your questions into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. The webcast will also be available on the link you have there at www.fccm.org/sepsis-redefined and also on FCCM's YouTube channel within 3 business days. We encourage you to post on Facebook if you like this webcast and to continue the conversation on Twitter using @SepsisRedefined. If you would like more information about the new sepsis definitions, please visit the links below. On our FCCM website, we have www.fccm.org/sepsis-redefined, or at the European Society of Intensive Care Medicine website, www.esicm.org/webinar-sepsis. On the Surviving Sepsis Campaign website, www.survivingsepsis.org, and the slides from today's presentation will be available soon on the FCCM website at www.fccm.org/sepsis-redefined. Now I am honored to turn the program over to Dr. Deutschman.
Thank you, Greg. If I could get the next slide, please. All right, what we're going to talk about briefly at the beginning of this webinar is the deliberations and determinations of the Third International Consensus Task Force for Sepsis and Septic Shock, what we have come to affectionately call Sepsis 3. Next slide, please. Can I have the next slide, please? The first issue that we need to discuss is why there was a sense that, I'm sorry, we're a slide ahead of ourselves again, that there was a problem with previous definitions. Now, the initial definitions were first formulated in 1991. They were revisited in 2001, but little changed. Problems that have arisen literally since their initial inception were the fact that these original definitions were SIRS-based, that is, on the systemic inflammatory response syndrome. They identified and promoted a new concept, that of severe sepsis, which has proven in some people's estimation to be problematic. And finally, the criteria could be interpreted in a number of different ways, and the differing assessments yielded dramatically different results. The question about SIR sensitivity can be addressed very quickly and is highlighted in these two studies noted here. The first by Kokkonen et al. In the New England Journal of Medicine recently, and the second by Čerpek. In both of these studies, application of the SIRS criteria was examined. In the first study to patients already in the intensive care unit, in the second study to patients who were on the wards in a number of hospitals. The first study concluded that a substantial number of patients who were in the ICU never exhibited 2 or more SIRS criteria, which would have been required to meet the diagnosis of severe sepsis. The second study identified a large number of patients on the wards who did indeed meet 2 of the 4 SIRS criteria, but clearly were not critically ill. So SIRS may be an appropriate response to infection or any other stimulus that activates inflammation, but concerns have been raised very early that it was not pathognomonic for sepsis. Next slide, please. Indeed, when most people say sepsis, what they mean is severe sepsis. They are talking about critically ill patients whose care is intense, requires multiple interventions, and the participation of trained specialists from multiple walks of medical practice and practitioner care. What the initial 2 task force called sepsis is what most people would now call infection. That is a response that is systemic to some kind of ongoing inflammatory infectious stimulus. Next slide, please. In a classic study, Gajewski et al. Examined a data set that they comprised to be indicative of patients across the United States. Within this data set, which ran from the years 2004 to 2009, they noted that the incidence of sepsis, i.e. the number of cases, increased, and they noted that the total mortality also increased, but not quite as much, so that the overall relative mortality, the rate of death, declined. However, what's most important here is that using 4 different ways of defining sepsis yielded divergent results. You can see that the incidence ran anywhere from 900,000 cases to 3.1 million cases in 2009, depending on the abstraction method used, and the mortality from 250,000 to 375,000. So indeed, 4 different ways to code for sepsis yielded 4 different sets of results. One of the key findings in the study that was performed by Shankar Hari et al. That comprises one of the 3 papers published from the Sepsis 3 task force examined the incidence of septic shock across different nationalities and across different healthcare systems. Now, importantly, all of these systems are highly developed, highly sophisticated, highly technological systems. As you can see, the mortality from septic shock in Australia was about 22%. This mimics what's found in the United States. However, Germany and the Netherlands reported mortalities upwards of 60%. So clearly something is very different about the way these different groups in these different nationalities are defining or looking at septic shock. Next slide, please. Thank you. We also have an increased understanding of septic pathobiology. We understand, as I've said, that it's more than just unimpeded inflammation, that beyond being containing elements of uncontrolled inflammation, there are also elements of immunosuppression, immune systems that simply don't work properly. Non-immune mechanisms are known to contribute. This may not be just a disorder of the immune system. It is possible that some of the early elements that comprise organ dysfunction may actually be adaptive, and there has been a reappraisal of the nature of septic shock. Next slide, please. As a result, the ESICM, the European Society of Intensive Care Medicine, along with the Society of Critical Care Medicine, convened the task force to redefine sepsis. The co-chairs were myself and Mervyn Singer from University College London, and this lists the membership. As you can see, both our moderator and my co-panelists were members, along with a number of other distinguished individuals. Next slide, please. And this is the document recently published in the journal JAMA. Next slide, please. So what are the new definitions? Well, we have to take a step back and talk about what we really mean by the word definition. How does one define definition? Looking in the Merriam-Webster English Dictionary, one finds that a definition is a statement expressing the essential nature of something, or more generically, a statement that describes what something is. A definition, therefore, requires an understanding of the pathobiology of a medical disorder, which for sepsis, at the very best, is incomplete. I would defy anybody to tell us what sepsis is. Therefore, we came up with the following definition. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Now, this reflects the most up-to-date information regarding the underlying pathobiology, the pathophysiology, immune abnormalities, et cetera, that comprise the syndrome that we refer to as sepsis. Clearly, this will be subject to definition, to revision as we learn more, but for the moment, this is the closest we can come to saying what sepsis is. Sepsis shock, septic shock, similarly, was a bit more problematic. Septic shock could simply be viewed as sepsis where the organ dysfunction occurs in the cardiovascular system. It was the task force opinion, however, that this was not the case because cellular and metabolic abnormalities outside cardiovascular dysfunction were part of the syndrome. We thought then, what is it that distinguishes septic shock from sepsis? The treatment doesn't differ. The management based on the Surviving Sepsis criteria is exactly the same. There might be a difference in the underlying biology, but we don't know that at this time. So we're left with a need to identify some difference between sepsis and septic shock. And the most tangible difference lies in mortality. If sepsis is really bad infection, then septic shock is really, really, really bad sepsis. And therefore, septic shock was defined as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Now, there are some advantages to these new definitions. For example, they incorporate the most up-to-date thinking on sepsis pathobiology, and they provide the closest approximation possible to describing what sepsis is. However, there are some deficiencies as well. For example, these definitions are of limited practical utility. They contain elements that simply can't be identified. Organ dysfunction is something about which reasonable people argue on a regular basis, and it's difficult enough to identify what constitutes clinically a regulated host response, never mind a dysregulated host response. And that led us to the second phase of our deliberations and our work, which was to come up with clinical criteria that would help identify those patients who were likely to have sepsis. The first of these was identified in this paper, lead author Chris Seymour at the University of Pittsburgh. Chris started out to look at our definition of sepsis and determine what clinical criteria could be derived from this definition that might be of value at the bedside. Life-threatening organ dysfunction caused by a dysregulated host response to infection. So We start out by limiting ourselves among patients with suspected infection, and our proxy, if you will, for organ dysfunction, for sepsis itself, is who is really sick among the patients with infection. Another way of looking at it is to say that among the subset of all patients we see, some have infection, and within those that have infection, there's a subset that are really sick, and that subset constitutes the patients who are septic. The challenges were, how do we derive a data-driven set of clinical criteria? Previous criteria were basically the result of expert opinion. How do we identify infection? What clinical criteria should be studied? And how do we identify who's really sick? And the Pittsburgh group chose to address each of these in turn. The data source was based initially for derivation upon 3.1 million electronic health records from the University of Pittsburgh Medical Center, and it was validated among almost 6 million records from 4 additional data sets, one from the Kaiser Permanente Northern California group, one from the U.S. Veterans Administration system, the alerts database from Germany, and the emergency medical system database from Kings County, Seattle. The identification of infection from among those groups was simply to look for the first episode in which cultures were sent and antibiotics were started. Using that criteria, 148,000 records with suspected infection were identified from among the University of Pittsburgh Medical Center data set, and additional 700,000 were identified when the other 4 data sets were included. Clinical criteria to study, well, there are some criteria that have been in use for quite some time. SIRS, which consists of a score from 0 to 4 points and includes abnormalities of temperature, heart rate, respiratory rate, and white blood cell count. The SOFA score, which is frequently used by intensivists but may not be so well known or used by those outside the intensive care unit. And the LOADS score, which is logistic organ dysfunction scoring system, similar to SOFA, and again, more familiar to those who work in the intensive care unit than those who do not. The identification of really sick was also problematic. Sepsis is life-threatening organ dysfunction caused by a dysregulated host response. However, these are unmeasurable variables. We really can't get a handle on either one of these things. So we had to use proxies. Can I get the next clip, please? Among the proxies available were a number of different things. We could use, for example, coding for discharge diagnoses. We could use clinical review committees. We could use prolonged ICU stay, death in the hospital, or positive microbiological cultures. The group at Pittsburgh chose to use the combination of death in the hospital and a prolonged ICU stay that is greater than 3 days as their criteria for really sick. That is to identify as best as possible those patients within the subset of patients with presumed infection who were likely to be septic and who met criteria for being really sick. Next slide. There we go. As you can see, when we look at a number of different possible systems, you can see that there are differences within the ICU and outside the ICU. Within the ICU, the great majority of patients who, with infection, do meet SIRS criteria. Those without any SIRS criteria or with only one are much fewer, although they are present. Similarly, the SOFA score above a certain cutoff and the load score above a certain cutoff are fairly good at identifying the truly sick patients from the ICU. Outside the ICU, there's a different story. SIRS criteria are most heavily distributed even among those patients with suspected, presumed, or identified infection, are much more evenly distributed, and the great majority actually would barely meet criteria for sepsis based on the old severe sepsis definition. Similarly, both the SOFA score and the load score are weighted towards lower scores and are less likely to identify really, really sick patients. Further, both SOFA and loads are complex, and they require at least several laboratory tests and studies and measurements, including some interventional variables. SIRS does require a single laboratory test, white blood cell count. In developing new criteria, a number of variables initially drawn from Sepsis 2 were identified. Multiple logistic regression was used to determine which were the best possible indicators of poor outcome, of death or long stay in the ICU, and what combination might work best. And the result was the identification of what is now called QSOFA or quick SOFA. Using criteria that include a respiratory rate of greater than 22 breaths per minute, a change in mentation, or a systolic blood pressure of less than 100 millimeters of mercury, and validated with other data sets, the QSOFA was capable of identifying a large number of the individuals who ultimately went on to spend a prolonged time in the ICU or to die. What you can see from this analysis is that with patients in the ICU, both SOFA and loads work better than SIRS and somewhat better than QSOFA. However, outside the ICU, all three systems are superior to SIRS, and indeed QSOFA in particular is not only superior to SIRS, it is probably easier to measure because it involves only 3 clinically measured variables and no laboratory values. Serum lactate has been touted as an outstanding marker of impending sepsis, and clearly has predictive validity for mortality. However, when it was added to the QSOFA and the same analysis was performed, it didn't improve substantially the identification of appropriate patients. So, the new definition of sepsis: life-threatening organ dysfunction caused by dysregulated host response to infection. The new clinical criteria: among those patients with suspected infection, a SOFA score of greater than 2, or a change of greater than or equal to in the SOFA score, which some people have called delta SOFA, or in the ED or on the wards, the QSOFA measure. So these are the newly identified clinical criteria that can be used to identify patients with suspected, presumed, or identified infection who are likely to progress to a poor outcome, that is, who have an outcomes validity to the score, provide outcomes validity. Criteria to identify patients with septic shock were somewhat more problematic. They began with, I'm sorry, can I have the next slide again, please? They began with the new definition, which was arrived at by consensus. As with sepsis, there are elements within here that are difficult to identify, for example, cellular and metabolic abnormalities, and what constitutes a greater risk of mortality than sepsis alone. Therefore, Shankar Hari et al. Performed analyses that were similar to those that were done with the sepsis, looking at the sepsis criteria, looking to identify a subset of sepsis in which profound circulatory, cellular, metabolic abnormalities were associated with a greater risk. So these are the patients who are especially sick. How do we identify them? Well, we start with the subset of patients who have infection and are really sick. We looked at hospital mortality as an outcome, and we wanted to find out people who had a higher risk of hospital mortality than with sepsis alone. The random criteria chosen was about a 50-50 chance of dying. So again, to use this diagram, we have patients who are infected and who have sepsis. Among those patients, there will be patients who have septic shock. The identification of those patients with septic shock within the group of really sick patients are the patients who are really, really, really sick. And we started looking for proxies for really, really, really sick. Next slide, please. Once we used a different derivation cohort this time, Shankar Hari et al., starting with the Surviving Sepsis Campaign data set, which identified a little in excess of 28,000 patients who met criteria for severe sepsis or septic shock. That was how they were entered into the data set. Validation cohorts from the PIT data set, the UPMC data set, and the Kaiser Permanente data set. Criteria identified by Delphi process among the members of the task force was potential criteria would include after fluid administration, ongoing hypotension, dependence on the use of vasopressors to maintain a blood pressure, and an elevation in the serum lactate level. Using these three variables, one could identify 6 different groups based on the combination of hypotension, vasopressors, and lactate. Of these 6 groups, 2 had small enough numbers that they were not included. This left 4 different sets. And as you can see, group 1, which had both hypotension after fluids, ongoing use of vasopressors, and an elevation of lactate, had a mortality of about 42%, which was statistically different than the mortality in all the other 3 groups. So therefore, the new septic shock definition, a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with greater risk of mortality than sepsis alone. Despite adequate fluid resuscitation, these patients can be clinically recognized by an ongoing need for vasopressors to maintain their mean arterial pressure greater than 65 millimeters of mercury and a persistently elevated lactate. Next slide, please. So to summarize, we have new definitions of sepsis and septic shock. Sepsis is defined, and again, I emphasize the difference between a definition and clinical criteria to identify patients. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is defined as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. Outside the ICU, patients with suspected or presumed infection who are highly likely to have poor outcomes, that is, death or a prolonged ICU stay, can be clinically identified using the QSOFA measurement. That is, systolic blood pressure less than 100 millimeters of mercury, a respiratory rate greater than 22 breaths per minute, and a change in mental status. Within the ICU, the septic patient can be identified by a SOFA score of 2 or more, or a change in the SOFA score of 2 or more in patients who have pre-existing abnormalities that elevate their SOFA score at baseline. Finally, septic shock can be identified by, can be clinically identified if, despite adequate resuscitation, patients have an ongoing requirement for vasopressors to maintain their blood pressure. Patients have an elevated lactate in excess of 2 millimolars per liter. And it's important to point out that both of these criteria need to be met clinically to identify the group of patients with a mortality in excess of 40% from among those who meet criteria for sepsis. And on that note, I will turn the discussion over to Dr. Levy. Thank you very much.
Thanks, Cliff. So I'd like to, let's see. Can I advance my own slides? I can. So I'd like to talk, I'm not going to take much time because I think Cliff really did a very nice job, obviously, of covering the new definitions. I just wanted to talk for about 10 minutes or so to put into context some of the definition, and also then we'll open it up for questions, which I think is probably the most important aspect of the program. So there are, we're very well aware, both the panel members from the definitions task force and the professional societies, the impact of the new definitions and the potential new definition from CDC, which I'll mention in a moment, the ongoing Step 1 for those of us in the United States, public mandated public reporting to CMS for sepsis. So this is the stuff I'm about to show you is from a piece that came out in Critical Care Medicine at the same time on the same day as the sepsis papers came out in JAMA. And these papers came from a group of us, and again, our moderator and Dr. Deutschman are both on this paper. This was a series of meetings we had at the Centers for Disease Control in which we started talking about the CDC efforts to create a surveillance definition and trying to create a sense of how we handle all these definitions in the field. So I think the problem is, although we're making our best attempt to advance the field with Sepsis 3, and I think we've done a remarkable job of doing that, the truth is there's no perfect way, no perfect method to unambiguously categorize patients as having sepsis or not. And I think Cliff described that already. And probably most important for my piece here is there are ongoing multiple initiatives for sepsis with different goals. And I think because there are these initiatives, different definitions, for now at least, are going to fit these different goals. I'm having trouble advancing the slide. So I'm unable to advance. There we go. What I'm going to show you is a series of tables that we think describe the 4 broad purposes for sepsis criteria and different definitions. And they include clinical care, research, both basic science and clinical, surveillance, and for quality improvement and audit. So let's look at clinical care. Can someone take over the slides for me, because my screen seems to still be very slow. So there we go. So this is clinical care, and what I'm going to show you in the next few slides are the objectives for each of these 4 categories, an example of them, the criteria that are currently being used, and some of the descriptors or caveats about their use. So for clinical care, the objective would be to inform the direct clinical care of sepsis in the bedside. And I think the example of that was just described by Dr. Deutschman, which is the Sepsis 3, the 3rd international consensus definitions. You already heard at length the description of the criteria, both for SOFA in the ICU and QSOFA outside the ICU. And some of the things to remind us is that sepsis is not restricted to confirmed infection. There were no criteria proposed for infection, and that's left to the clinician. And in the discussion period, we might wind up talking about the ongoing use of SIRS for exactly that purpose. And probably important, SOFA, since the SOFA score and the QSOFA, at least we're looking at delta, may not always be available at baseline. Next slide. So for clinical purposes, we can describe the objective. This is for research, clinical research, to guide the conduct of clinical research in sepsis. And there are multiple examples of that. All the clinical trials that are going on already, in this case, the ACCESS trial. And still, in the ongoing clinical trials for severe sepsis and septic shock that are underway, the clinical criteria are much the same as the old criteria. Needless to say, for trials that are in progress, we're not going to alter the inclusion criteria and the identification criteria, so we'll still wind up using some combination of the SIRS criteria, some evidence of major organ dysfunction, and in this case, using Apache 2 to identify high risk of death. So this is an example for clinical research where that the old definitions really won't change. Basic research also really is something that has had and will currently continue a different set of criteria. obviously for basic research, it's to guide the fundamental principles of sepsis, and for the most part in animal models. An example of that is the murine sepsis score after fecal-induced peritonitis. And you see here a classic scoring criteria used for identifying sepsis in animal models. And so clearly for basic research, there's an entirely different set of definitions and clinical criteria that are necessary in that arena. So you have, regardless of our advances in moving forward in a clinical arena, certainly for basic research, that's going to be different. Next, what you see is for surveillance and epidemiology. And I'll tell you that when we started meeting with CDC, at first we thought we, being the members of the task force, would be able to harmonize the definitions that are being planned by CDC for surveillance along with ours, and that turned out not to be the case. For those of us in the United States, the CDC is under a mandate in Congress to begin surveillance to identify the epidemiology of sepsis in hospitals. And so their proposed criteria, now these are just proposed, they're not published yet, but they're proposed criteria. And the idea for CDC is to identify local and national burden of incidents by surveilling hospitals. And in particular, they're trying to do this so that we're not dependent on coding any longer for identifying the national incidence of sepsis, and more importantly for infection control experts to try to be able to develop a set of criteria that could be pulled directly from the EHR and therefore reduce the data collection burden that's already in existence, in particular in the United States, for the CMS measures. And so these are the preliminary criteria, and you'll see here in a second that there we go. Oops. The criteria being proposed, and this was developed by centers that were funded by CDC in WashU in St. Louis and at the Brigham Hospital in Boston. So identifying amongst patients with infection more than one of the following: vasopressor use, greater than 2 days of mechanical ventilation, or a rise in serum creatinine of greater than 0.5. And the purpose here was to choose elements that are readily available in the electronic health record, and some feasibility of data collection, and to try to avoid how clinicians provide organ support, and therefore just get some objective criteria that might allow for surveillance of sepsis and septic shock. So really, that's all I have to present, and in the interest of struggling with these slides, I'm going to stop here, other than to conclude that I think what I tried to show you as a follow-up to Dr. Deutschman's presentation is, to a great extent, for better or worse, we're going to have to live with multiple definitions and multiple clinical criteria for identifying sepsis and septic shock. And there are different purposes. I showed you the purposes of research, both basic and clinical, the surveillance definitions that we're likely to see come soon from CDC, and then the ongoing quality improvement and audit that's required, at least in the United States, for mandated public reporting for the SEP1 initiative from CMS. I can tell you that CMS currently does not have plans to adopt our new definitions, and they are going to continue to use the criteria and definitions that they began with in their initiative as of October 15th, 2015. So for better or worse, I think that we've tried to, as Cliff identified, really advance the field with, we think, are the first data-driven clinical criteria for sepsis and septic shock, and at the same time acknowledge that certainly QSOFA, as we said in the manuscript, will need to undergo further prospective validation, while also understanding that other initiatives like CDC and CMS will continue to use different definitions, and perhaps someday and over the next several years we'll see it all harmonized into these new definitions, but that's not currently the case. unfortunately, for many of our data collectors and hospitals, at least in the United States. And so I'll stop there and turn it over to Dr. Coopersmith to open it up for questions. Thank you.
Thank you, Dr. Levy. Thank you to everybody listening. We have a number of questions, and I'm going to immediately get started. We have a number of questions about QSOFA, and I'll start with that. And I'll start for Dr. Deutschman. I have a question that says, QSOFA incorporates mental status, blood pressure, and respiratory rate. How is urine output incorporated in this assessment? A patient with a positive QSOFA who has maintained good urine output and thus ability to compensate for metabolic acidosis is likely to fare better. Any thoughts?
Sure. Let me start by saying that, as Dr. Levy pointed out, QSOFA is something that was derived using a number of large data sets. Overall, there were in excess of 6 million patient records that were looked into. 850,000 of them met criteria for suspected infection. That is, they had received antibiotics and had cultured sense. And the analysis was done using a number of different potential identifiers, including urine output, to determine which elements best identified those patients who went on to have poor outcomes. So the low urine output was indeed one that was measured. It didn't work as well as the combination of the three vital signs, the three assessments that comprise QSOFA. When it was added to QSOFA, the predictive validity was not improved substantially. So by itself, low urine output, or added to the elements that comprise QSOFA, low urine output, didn't help identify within the data sets that we studied patients who went on to have a prolonged ICU stay or to die. That's not to say that low urine output isn't a useful marker. It is indeed a useful marker. It just doesn't substantially add to this particular assessment. Keeping in mind that there are lots more than 850,000 patients to assess, keeping in mind that everybody's patient population looks a little bit different, and keeping in mind that as we expand the application of these new clinical criteria, we'll learn more about how well they work. The most important thing of all to keep in mind in all of this is none of this, QSOFA, SOFA greater than 2, definitions, SIRS, anything you can come up with, none of this is designed to supplant the clinical acumen of a trained clinician. These are designed, QSOFA in particular is designed to provide a prompt that something more may be going on. It doesn't say by its absence that nothing is going on. If you have that funny feeling in the pit of your stomach at 2 o'clock in the morning that's telling you that no matter what the vital signs say and no matter what the lab values look like, this patient doesn't look right, go with it. Clinical judgment is still of paramount importance, and everybody knows the extent to which they ought to rely upon their own judgment. So again, to be perfectly clear, none of this is intended to in any way delay treatment. None of it is saying if you don't have these things, the patient can't possibly have sepsis. That's absolutely not true. What it's saying is that these things may help you identify patients who will have a bad outcome and who are likely, therefore, with infection to have sepsis. It doesn't in any way intend to obviate, though, strong clinical judgment.
Thank you. We've got some more questions on QSOFA. Well, these are related. The first is, does QSOFA perform differently in different age groups? And the other is a more broad question. How do these criteria apply to pediatrics?
Again, an excellent question. The answer to the first question is we don't know. I'm under the impression that analysis by age group is ongoing at this time, and hopefully based on the data sets already examined, that information will be forthcoming. We should also absolutely say, without any condition whatsoever, that this does not apply to pediatrics. It has not been studied in pediatrics. It has not been verified or derived from pediatric patients. The data sets were limited to patients over the age of 18 years of age. Now, there are ongoing efforts being organized to address similar potential identifiers in children. These efforts are just starting, and hopefully we'll have an answer to that question sometime soon. But again, to reiterate, we don't know about age group distribution, and these criteria were not derived from a data set that included pediatric patients, so they should not be applied to pediatrics.
Thank you. Next question is also on QSOFA. So there's three elements of QSOFA: respiratory rate, systolic blood pressure, and mentation. And the question is, we can easily objectively measure respiratory rate and systolic blood pressure. How do we objectively measure altered mentation?
Another really good question, and one that we struggled with. The initial derivation, which, because of the way it was done, required something quantitative, was based on a change in the Glasgow Coma score. Now, this is not something that's universally measured or recorded. So the analysis that led us to use the Glasgow Coma score and to come up with an abnormality in the Glasgow Coma score as one of the elements of QSOFA was of necessity limited. However, there are other ways of identifying alterations in mental status, some of which are recorded, many of which are not. We were able to get fairly substantial numerical estimates of mental status. For example, the VA has a system of identifying alterations in mentation that is different from the Glasgow Coma score. It's different, frankly, than something I've seen used anywhere else. But it's there, and when it was used in place of the Glasgow Coma score in assessing QSOFA, it seemed to work perfectly well. So we expanded the definition to include the clinical criteria to include any change in mental status, since the change in Glasgow Coma score was any change in Glasgow Coma score. Using the data that are available, this held up. Again, all of these things need to be extensively evaluated in other settings. They need to be evaluated prospectively. If you have a system that you use in your emergency department, your ICU, on your wards to evaluate patients' mentation, that should be checked as well. All these clinical criteria are open to further evaluation. In fact, they absolutely must be evaluated more extensively and revised as needed.
Thank you, Dr. Deutschman. The next question is for Dr. Levy. So the Surviving Sepsis bundles and SEP Core 1 measures, we understand they're not the same thing, but are either of them going to be revised in the future? And if so, when?
Yeah, that's a good question, although I want to I also want to make it clear, I want to take the opportunity, the new definitions and SOFA and QSOFA, apart from the change in terminology of sepsis and severe sepsis, have nothing to do with the management of these patients. And I think there's also been a lot of concern expressed based on some misunderstanding that, and I think Cliff alluded to this, that you would use the new definitions in any way to alter your management of these sick patients. So again, the trigger for currently the 3-hour bundle and the 6-hour bundle remain the same for both the Surviving Sepsis Campaign and the Step 1 or CMS. And over time, as the QSOFA outside the ICU begins to be tested and in fact shows confirms the greater sensitivity and specificity over and above the current screening tools, I think that you'll see widespread adoption by CMS and others of QSOFA outside the ICU for this. But for now, the bundles themselves are certainly not going to be revised until there are new data, perhaps in the next release of the Surviving Sepsis Campaign guidelines that would inform the change in the 3 and the 6 hour bundle.
Two follow-ups to that. Can you tell us when the new Surviving Sepsis Campaign guidelines are going to come out? And if you envision any changes in the CMS Step 1? I know you touched on it, but we do have a question on it.
So we're all hoping that the 2016 guidelines will come out in 2016. But if I had to guess, I would say that they would come out at the same time as they came out in 2012, which is January of 2017, in time for release during the Society of Critical Care Medicine's meeting in Hawaii this year. And as far as Step 1, I do know that CMS has written a letter to JAMA for publication in which they will announce that they will not be changing any of their current initiatives for the Step 1 measure. And that means the screening, the use of STIRS, and the criteria for the 3 and 6 hour bundle will remain unchanged. And I think they ended by saying that they're certainly open to new data as it comes available, but for now, they're going to continue with as they were doing before. And in many ways, that's why we did put out this other manuscript in which we showed the likelihood and utility, for that matter, of different definitions and different criteria for different initiatives.
The next two questions are related for Dr. Deutschman. Has severe sepsis been eliminated in Sepsis 3? And if so, from a practical standpoint, is severe sepsis no longer a codable diagnosis, at least in the United States?
Well, I can answer the second one more easily than the first one. The answer to the second one is I have no idea. From a coding point of view, the criteria are what they are. I don't know that they're going to change anytime soon. Based on what Dr. Levy just said about CMS's intentions, it's unlikely that that will happen. Now, severe sepsis has indeed been eliminated from the lexicon. Why is that? Well, because by and large, in the vernacular, when people mean severe sepsis, they say sepsis. When they mean what used to be called sepsis, they mean infection. And based on the new definitions, the definitions now, not the clinical criteria, but the definitions, the hallmark of sepsis is the presence of some form of organ dysfunction. However occult, however difficult to measure, organ dysfunction is part and parcel, a key element of the syndrome. Therefore, the terms sepsis and severe sepsis are redundant. They mean the same thing. Infection is simply someone with suspected infection who meets 2 of the 4 SIRS criteria. And when you think about it, that's pretty much anybody with an infection on just about any level. Flip side of it is, absent some form of organ dysfunction, the risk changes. In the infected cohort across the board, that is the 850,000 patients who met criteria for suspected infection, including those who met criteria, the 150,000 or so who met criteria for sepsis, the overall mortality was less than 5%. So again, taking out the patients who did go on to die, did go on to have poor outcomes, the mortality from suspected infection alone is very low. And most of those patients met 2 or more SIRS criteria. So again, the point is just that in the context of the new definition, where organ dysfunction and a dysregulated host response are pathognomonic for sepsis, there is no need for 2 separate terms.
I'm going to follow up on what you were just talking about with mortality with the question that says, with these new definitions, what benchmarks do we have for mortality? Do we keep the ARISE and process benchmarks of 18 to 22%, or is it something new and different?
Yeah. Go ahead, Mitchell.
Well, first of all, I think that the benchmark for mortality and sepsis is the 18% from process and ARISE would be a grave mistake, as I think anyone who's collecting data on septic shock in their institution know The current benchmark in the Surviving Sepsis Campaign is somewhere around 25%, and that's generous. So I think we have to be careful about thinking that a mortality rate from a randomized controlled trial would serve as a benchmark for those of us in clinical practice. So I'll leave the rest for you to answer, Cliff, but I felt I just had to interject that.
No, I think that pretty much covers the point. Part of the driving force for this entire task force process was the fact that there is no clear benchmark for mortality. There are a number of reasons that might explain that, but clearly what the mortality from septic shock or from severe sepsis in the United States and in Australia is very different from that of most of the industrialized nations in Europe, whose medical system is very similar to us in terms of technology and access, et cetera, and may actually be superior to ours. To some extent, it's based on the availability of ICU beds. Both Australia and the United States have a relative excess of critical care beds, while the United Kingdom, France, Germany, Italy have far fewer and have to utilize those beds more judiciously. So to go back to the Gajewski paper, how you decide to identify patients with sepsis will very much determine what your incidence and what your mortality are.
Thank you. There was a little bit of confusion from some people about the clinical criteria of sepsis. Is it a SOFA score greater than 2 or a change in SOFA score of greater than 2?
Yes. The answer is both. The way the original data were derived was simply calculating the SOFA scores based on what was available from the electronic medical records. So there was no way to really detect a change, at least in the initial formulation. The assumption there was that people at baseline had a SOFA score of 0 before they got ill, and that if their SOFA score rose by 2 points, and again, this was objectively measured, patients whose SOFA score rose from 0 to 2 or more went on to have poor outcomes. Now, in additional analyses where there were data available on baseline abnormalities, again, a much more limited analysis, the change in SOFA score of 2 with patients who, for example, started with some pre-existing renal, neurological, or hepatic dysfunction, a change of SOFA of 2 or more also predicted poor outcomes. That's a much more limited data set, although it does seem to work. Again, these are things that require ongoing validation, prospective validation. They need to be looked at in much more depth and detail. And the big advantage of doing this prospectively is that you can start out knowing what the baseline SOFA score is and actually determine if there's a change and if that change is an identifier.
I'm going to ask Dr. Levy a very straightforward one. How do we identify adequate resuscitation?
Oh, boy. And I have a very straightforward answer. No idea. I think we all would love the answer to that. We've been looking for the answer for that in critical care for well over 20 years. And unfortunately, everybody has a different method, whether it's using one of the various hemodynamic minimally invasive methods, whether you use lactate clearance. There are a whole host of methods for doing that, none of which have clearly been proven via large trials to be successful in identifying the term adequate. So unfortunately, we're all left to our own individual decision-making about what is adequate.
But there's an extension to this that's actually really important, which is to say that the notion of adequate resuscitation as a criteria only comes into play when we're talking about septic shock. There's nothing about the resuscitation per se that figures into looking at SOFA, for example, a change in SOFA, or looking at QSOFA. And the importance of a label of septic shock may be of nothing more than epidemiologic value at this point, which is to say, you're not going to treat the patient differently if they're hypotensive and they meet criteria for septic shock, or if they meet criteria for sepsis but not for septic shock. They're still going to get antibiotics. They're still going to get fluid. You're still going to worry like hell about them. If it's your approach to move them to an ICU, to order additional labs, to order additional tests, you're still going to do that. Identifying somebody as having septic shock, which is where the requirement for adequate fluid resuscitation, whatever that means, comes in, may not affect individual patient care.
So let's follow up on septic shock. I have somebody who's asking, why are patients who are vasopressor dependent to maintain a MAP of greater than 65, but do not have an elevated lactate of greater than 2, why are they not considered to be in septic shock in the new definition?
Again, this is purely a matter of data analysis. Very simply, our criteria, criteria for the identified definition was patients who were really, really sick. The proxy that we used for really, really sick was really, really high mortality. And the mortality for patients who are pressor dependent, but do not have an elevated lactate, is not significantly higher than that of those who meet criteria for sepsis alone. On the other hand, the presence of both pressor-dependent hypotension and an elevated lactate pushes the mortality within the data sets that we examined from 25% to in excess of 40%. So this was simply the way we identified those patients based on the data. Now again, additional data may change that. Additional clinical criteria may change that. But as of the moment, the ability to identify a patient whose mortality is appreciably higher, statistically significantly higher than a patient who has sepsis alone is only present when both those criteria are met.
So Dr. Levy, we have a question that says, while in theory, it's helpful to have multiple different working definitions of sepsis, in practice, this could be confusing because how do we let the coders know if we're talking about new sepsis or old sepsis? Are we creating a further burden? And what are the challenges involved with this and how do we respond to that?
Yeah, that's a great question, and I should be clear that it's not so much a theory that I proposed. It's almost that necessity is the mother of invention. So there is no question that harmonizing all these definitions would be best. But just keep in mind, again, that SEP 3 was proposed. It's something that we put out in the same way that we put out in the second iteration, we put out PIRO for evaluating the staging system of sepsis. So we were under no illusion amongst the task force that this was going to be instantly generally adopted by everyone. The truth is that for data collectors who are involved with SEP 1, they just need to keep concentrating their efforts on that and in many ways not worry about the new definitions. As far as coding goes, I think it's a very important point. Cliff already mentioned the ICD-10 codes are not going to change anytime soon. And if you look in the manuscript, we actually suggest the code to use for sepsis, and that code is severe sepsis. So there's no question this is confusing. We are essentially telling the field to say sepsis, but code for severe sepsis. And I wish I could tell you that there was an easier way to do this, but the truth is if we are to move the field forward, and I do think that infection, sepsis, and septic shock are terminologies that really better reflect our clinical use of it. If we're going to move the field forward and adopt that, we have to accept that coding for the financial stability of providers and hospitals has to remain unchanged. That is, when patients have infection and organ dysfunction, we're going to say sepsis, but we're going to code severe sepsis.
Okay, here's questions about screening outside of the ICU. I have questions about the use of both QSOFA and SOFA outside of the ICU. Should we use QSOFA on the wards, in the ED, and even in the ambulance? And should we be using SOFA outside of the ICU, for instance, in the emergency department?
It's a practical question. The answer is yes, and it's a practical question. The advantage that QSOFA has lies in its simplicity, lies in the fact that it can be done very quickly, lies in the fact that it consists of 3 measures that are part of any assessment in virtually any patient. A patient rolls into the emergency room, a patient is taken into the ambulance. You'll count how often they're breathing. You'll measure their blood pressure. You'll take an assessment of their mental status. This is routine. SOFA consists of 13 elements, many of which are laboratory-based, a number of which are actually interventionally based. That is, for example, a requirement for vasopressors or a requirement for exogenous oxygen or mechanical ventilation. So these are not things that will necessarily be routinely measurable in a non-ICU setting, but they may be as well. Overall predictive value outside the intensive care unit, the SOFA of greater than or equal to is slightly better, but not appreciably so, and it's much more difficult to use. Within the ICU, which isn't really the question, the ability of QSOFA to function drops, in part because respiratory, we're controlling the respirations, we're controlling the blood pressure, and we're controlling the mental status with interventions. But outside the ICU, the beauty of QSOFA lies in its simplicity. It's a prompt that something bad may be going on. It's a prompt that you may want to get more information. It's a prompt that you may want to move the patient to a place or a locale where a higher level of care will be available.
Here's a very specific question. Your presentation mentioned both a map of 70 and the SOFA score. It says we use a map of 65, and your presentation mentioned both. It's a little confusing. What number should we use?
Just a little confusing? Yeah, we struggled with this. We actually have 3 separate numbers in there. QSOFA is based on the systolic blood pressure, and septic shock is based on a mean arterial pressure of 65, and SOFA is based on a mean arterial pressure of 70. These numbers basically reflect what was available in the databases. Keep in mind that the QSOFA was derived, and the original derivations on sepsis were derived from data where different mean blood pressures could be tested, and 70 seemed to be an appropriate cutoff. On the other hand, the original derivation of the clinical criteria for septic shock were based on what was available from the Surviving Sepsis Campaign database. And Mitchell can speak to this more eloquently than I can, but basically the number that's included in there is blood pressure above or below 65, mean arterial pressure of 65 millimeters of mercury. That was the number that was available, so that was the number that could be tested. Which are you to use practically? I think, again, we need additional evaluation to decide. What we have available says that QSOFA works with a mean of 70, and the criteria for septic shock are based on a mean of 65.
Getting to specific data here, I have a question that says, how do you make decisions in your analysis related to missing data? For instance, in your model, Glasgow Coma Scale was used, but missing data were a problem in the data sets.
Mitchell, are you still here?
I am.
Okay. I'm a non-epidemiologist. I can tell you what they told us we did. I can't pretend for a second I understand it. It's something called imputation analysis, which allows you to decide whether or not missing numbers are going to affect the results. That's the best I'm capable of understanding. Dr. Levy, if you have something to add to that, please do.
No, you just do various sets of sensitivity analyses to decide whether the data were extreme one way or the other would it affect the analysis, and based on the degree of and amount of missing data and the feeling from the team that worked on QSOFA is that it didn't.
Okay. I have a question related to QSOFA saying, how accurate is GCS in the intensive care unit?
Again, the answer is it depends. In a sedated patient, it's not accurate. In a non-sedated patient, it probably is. But again, keep in mind that GCS was part of the original formulation of QSOFA, and we said from the get-go that QSOFA simply doesn't work as well as other available methodologies in the ICU, and the elements that comprise SOFA in general are available for patients in the ICU, whereas they may not be with patients on the ward or in the emergency department. So again, the answer is self-evident. If you sedate a patient, Glasgow Coma score is not a helpful number. Change in mental status is not a helpful assessment. But presumably outside the ICU, sedation is not something that's being undertaken. And the data indicate that these are a number or an assessment that is viable.
Here's one that's relevant to operationalizing this. Is there a specific time interval gap that should be present for measuring the difference in SOFA score? Hourly, daily, some other time gap?
Again, a difficult question. The initial assessment looked at a time window of 24 hours. That is the compilation of the initial assessment, the initial blood pressure, the initial mental status, the initial respiratory rate, could be within 24 hours of the identification of suspected infection. Chris Seymour then narrowed this window down to six hours and got the same results. So effectively, what we can say is that within 24 hours works in the data sets that were examined. Within 6 hours also works. I think it was hoped that the 6 hour time interval would work better, and I don't think it did.
Okay. The next question goes back to what we were talking about CMS reporting. How do we handle documentation of sepsis, septic shock, SOFA, and QSOFA related to CMS reporting? I'll send that to you, Dr. Levy.
Can you say that again? And by the way, I'm going to have to jump off right after this. I apologize. Can you say that again, Chris?
Sure. How do we, from the standpoint of CMS reporting, report sepsis, septic shock, SOFA, and QSOFA score?
Yeah, so I want to really make it clear, and I know this is unfortunate, for the purposes of CMS and SEP1, there is no relationship to SOFA and QSOFA. For now, QSOFA and SOFA are outside of the SEP1 measures. They're not going to be used for screening. They're not going to be used for reporting. And for most hospitals, you're going to have to set up, if you're interested in adopting or testing QSOFA against SIRS and other measures, that's going to be outside of the SEP1 measure. The SEP1 measure will still ask you to look for SIRS criteria, documentation of severe sepsis or septic shock by the clinicians, and then compliance based on the identification of time zero with the measures in SEP1. That's just not going to change. So I think it's important that in our minds we completely separate out the new definitions from SEP1 and the CMS measure. That's the simplest way to put it, while we begin to think about in each institution how to transition and look at whether QSOFA and SOFA are really helpful for us.
Thank you. And since you're going to leave, I'll thank Dr. Levy. We have 12 more minutes that we can go on. So thank you very much, Dr. Levy, for joining us. And I'll leave Dr. Deutschman solo for the last 12 minutes.
Take care.
Thank you, Dr. Levy. So I'll give you this challenging one, Dr. Deutschman. QSOFA helps us identify patients who have worse outcomes, but how do we use QSOFA clinically in the ED setting to identify which patients to treat using the sepsis pathway? Should we be using a hybrid of SIRS and QSOFA? And how big a role does lactate play in the initial management?
So I'll reiterate, to answer this question, I'll reiterate what Dr. Levy said before, which is that SOFA, QSOFA, SIRS really don't say anything at all about management. This is about identifying patients. They're not prompting you to manage. They're not saying you ought to do this, you ought not to do this. Management decisions are based on clinical judgment. They're based on your assessment of the patient and what the patient best needs. It would be misleading of me to say that somebody who had a positive QSOFA ought to get the 3-hour bundle. Okay, this is one of the things that would prompt one to consider starting the 3-hour bundle, to order additional tests, to watch the patient very carefully and reassess every 15 minutes, to do any of a number of things that will direct clinical management. But none of these things are specifically designed to direct clinical management. As far as lactate is concerned, again, lactate carries with it the ability to identify, on some level, very sick patients. It carries with it some prognostic value. There are data that strongly suggest that a failure of an elevated lactate to get better as a result of therapy is a harbinger of bad things to come. But those are soft data, and once again, how one chooses to use them is based on clinical judgment, the application of the Surviving Sepsis guidelines, et cetera, et cetera. But to reiterate again, none of these indices, none of the coding, none of anything that we've been discussing today is intended to direct management.
So with that, I will ask you a couple of speculative questions. First, with the new definition of sepsis, how do we understand the concept of SIRS? Do we need a new definition of SIRS? Is SIRS still helpful?
Again, to reiterate what I said during my talk, and this is a very important question. I'm really glad it was asked because this is something that seems to have engendered a lot of concern and a lot of misunderstanding. SIRS indicates inflammation. SIRS indicates may be very useful in identifying the presence of an inflammatory process, the presence of an infection, potential presence of an infection. In my mind, SIRS is a component of a balanced, a normal inflammatory response. What your body is supposed to do when it's faced with an infectious challenge, a danger signal, something that's telling it that something isn't right. When you have an infection, you're supposed to mount a white count. You're supposed to get a fever. You're supposed to have your heart rate go up. You're supposed to breathe faster. These are the adaptive responses that we've evolved to deal with the challenges that our environment places on us. So SIRS retains its importance in that setting. Where it seems not to be helpful is in identifying an aberrant or dysregulated host response or the presence of organ dysfunction, the two things that are now felt to be the hallmarks of sepsis. Do we need a new SIRS? It's always useful to see if you can't make something better, especially if it can be done easily. I know I've had all kinds of communications from all kinds of people in all kinds of facilities saying, we use this code or that score or this thing that we've derived and it works great. And my answer is that's terrific. Test it on the biggest data set you can find on. If it works better than what we have, that's fantastic. If it works better than SIRS in identifying potential infection, fantastic. We should start using it. But these decisions at this point, in this day and age, with the technology available to us, absolutely need to be data-driven. They can't be simply, seat of the pants, I think this works, so let's do it. Providing the data is the way you demonstrate utility to a broad range of practitioners and not just to yourself.
So I have another question which I know is very important to you to answer, and I want to give you a chance to do so. I am very worried that if we use QSOFA as the triage in the ED, or frankly on the wards, that we will miss a number of patients who are quite sick until it's too late. A number of patients would deteriorate and we will be getting them too late. What are your thoughts on this?
Yeah, we've heard a great deal of this. It's a legitimate concern. The data don't support that it will happen. First of all, let's talk about what the data themselves show. What the data say is that, and again, we're not talking about sepsis, we're talking about outcomes validity, patients who progress to have a poor outcome. What the data on these 850,000 patients with suspected or presumed infection show is that virtually all the patients who were identified by SIRS will also be identified by QSOFA. On the other hand, there are a very large number of patients that will be identified by SIRS that are not identified by QSOFA, and the majority of those patients where there isn't an overlap do not go on to have poor outcomes. That is to say that SIRS identifies a large group of patients who are sick, but who do not progress to have poor outcomes. Now, that said, you only have to be wrong once, and there's obviously a risk of that happening. Above and beyond everything else, there's still your clinical judgment. There's still what I said, before about that funny feeling in the pit of your stomach, the thing in your back of your mind that's niggling at you that says, I've seen this before and I don't remember it fondly. When that's the case, act on your judgment. However, that, again, what these indices are designed to be are prompts. They're things that can reinforce your judgment or can make you question your judgment. And when your judgment is telling you one thing and a number is telling you something different, I would say the default is go along with the thing that's telling you the outcome's going to be bad. It's always, it's always better to be a little overzealous and to err on the side of safety as opposed to erring on the side of expediency. So again, these things are helpful. These things are prompts. These things in no way should stop you from initiating further workup, management, transfer, et cetera, to a patient that looks really bad to you. I would say the exact same thing, applies to SIRS. If you had a patient in front of you who had tachycardia, but no white count, no temperature, and no elevated respiratory rate, but he looked really sick, you wouldn't hesitate to start managing that patient. You wouldn't hesitate to order additional tests. The same token applies here. If QSOFA tells you, if you've got one positive QSOFA sign, but your judgment says this patient is going to progress to doing poorly, follow your judgment.
So we only have time for a couple more questions. I'm going to ask a couple of questions on timing and then end with a speculative future question. So the first timing questions are, do we have data about A, which identifies patients earlier, SIRS or QSOFA? And then another timing question is there a time frame in which all the new definitions should be met for an accurate predictor? For instance, there's the 6-hour bundle, so for CMS within 6 hours. So again, question number one is earlier SIRS versus QSOFA, and question number two is how quickly should the elements be met?
Okay, so the answer to the first question is we don't know. Remember that these measures were derived using retrospective data, and the way things were put together was to identify a time frame and then grab those measurements that were available within that time frame. There isn't anything that I know of that says you can acquire the elements of QSOFA earlier than you will acquire the elements of SIRS. Now, logically, you know, the three things that you're measuring in QSOFA don't require you to draw blood to send something to the laboratory. They require nothing more than, you know, a blood pressure cuff, a clock, and the ability to count, and the ability to do some assessment of mental status. But, you know, three of the four elements of SIRS require the same, you know, the ability to count and a thermometer. Only one of the four requires a laboratory measurement. But the answer to the first is we don't know about the time frame. That will require prospective analysis or a more intense evaluation of the retrospective data than has been done so far. As far as, you know, the timing and all that is concerned, we only have the data windows that were assessed. 6 hours works and 24 hours works. And that's about all we can say about it.
Okay. Final question. Is this the definitive definition of sepsis, or should we look to the future for something new?
It's, you know, it's definitive until something new comes along. You know, it's the new kid in town. This is the best we can come up with based on available data, based on what we understand from animal studies, from studies in cells, from patient data, from everything we can combine to come up with the best scientific formulation of what sepsis is. A study could be published tomorrow that would change everything. And we need to be prepared to adjust when that happens. You know, Dr. Levy has talked extensively about the fact that, you know, that billing and coding is not going to follow, at least not in the foreseeable future, these new criteria. We can't afford that. We need to be better than that. We need to be in a position, we have to have the ability to adapt when adaptation becomes necessary. As soon as someone comes up with something new and demonstrates that it works better, we need to be prepared to change. That's what our patients require. That's what our patients deserve. That's how we make the mortality from this horrible disease go away or go down. That's how we better serve the community. That's how we advance the science.
So I will take the final word as the moderator to say, and also as a task force member and an author on the paper, unequivocally, this is not the final word. It is sepsis 3, there will be a sepsis 4 and a sepsis 5, and we will get better in the future. But for today, this is the best we have. So I want to thank Dr. Deutschman and Dr. Levy for their efforts in preparing for and delivering this informative webcast. Thank you to our large audience for your participation and sending me a humongous number of questions. It was great to go through them. To access the recording and slides for today's webcast, along with other sepsis definition resources, please visit www.fccm.org/sepsis redefined. This concludes today's webinar. Have a great day.